Again, I thank you both so much for joining me. I'm really excited to have this discussion, and especially in anticipation of the article. I think that the timing will be really well received. So I'll start with you, Dr. Portwood. If you could just tell me a little bit about this article that you've put out, the title being Framing the Conversation, the Science, Practice, and Policy Related to Adverse Childhood Experiences, or ACEs.
Of course. So, as you may know from your conversations with Dr. Lawler, we wrote this article as an introduction to a special issue of the American Psychologist that we guest edited along with Dr. Michael Roberts at KU, University of Kansas. And the special issue was really in response to a lot of things that the three of us guest editors had seen happening around adverse childhood experiences, or what's more popularly known as ACEs. And that's a concept that really kind of caught fire in the past 5 years. All of us have worked for our careers around child maltreatment, child trauma, children's mental health, various forms of violence against children, and violence in families. And ACEs has really come into that space and gained a lot of popularity. We believe largely because it resonates with regular people. The original study that led to this discussion of ACEs was conducted by Felitti and some others in 1998. So at the time we were first thinking about the special issue, which gave rise to the article, it was around the 20th anniversary of that particular article. And it was really amazing to say that, you know, in the world of science, in only 20 years, you had one study that had given rise to this whole field of scholarship, and even moving beyond scholarship to see applications of that work. And it's all the more amazing because in some respects, the Felitti work was a little accidental in terms of what it found about adverse childhood experiences. Those researchers were physicians primarily and had done work in their obesity clinic. And one of the things they were noticing around this was that a lot of their patients reported a history of challenges in their childhood, or what we call adverse experiences. So those researchers had done this study to kind of look at how these adverse childhood experiences might impact adult health. And their findings were just so profound in terms of people having these experiences and seeing those create not only negative outcomes in their younger years, but that those were extending into adulthood, that it really caught the imagination of those of us who really try to work to make children's lives better, as well as those who are interested in adult health.
It's shocked me in learning about ACEs that there were some things that I would anticipate as being consequences of these experiences, but the actual health outcomes that seem to be happening over and over again with these groups that have these commonalities surprised me. Can you talk about some of those, the health outcomes, the problems that people face in later life that may not come along as a common expectation of course that would happen to somebody, but they seem to be recurring over and over again?
Sharon, you want to start that one?
Oh, I was going to see if you wanted to jump in there. It has been almost everything that people have studied. Yeah. So I don't have that original study in front of me, and to be honest, I've looked at so much work, I'm not going to be able to tell you exactly what that particular study found, with apologies to those very fine researchers. But over time, people were expanding to look, like I said, they were initially interested in weight, but they looked at, behavioral health issues, smoking. They looked at divorce. They found relationships around divorce, certainly profound mental health issues. That was maybe not as unexpected as the physical health issues. They just found, like I said, what always amazes me, and it's not really my area to look at the physical health outcomes, but almost every study you look at where somebody thinks of some novel condition that hasn't previously been studied and executes some research on that, they find that that negative outcome too is associated with ACEs, and particularly with heightened numbers of adverse childhood experiences.
Yeah. Go ahead, Dr. Lawler. I know that you have more to say on the topic.
Yeah, no, it's always a pleasure working with Sharon. Again, we were talking about COVID-19 times and having these opportunities to do these types of meetings, and I just appreciate it. Yeah, so there's this term biopsychosocial that kind of describes a lot of this work and these studies, but that developed over time. So we've known for a few generations now, or many generations, that things that happen to you when you're younger, they predict some things that happen later in adulthood. And ACEs, I think one of the reasons that it caught everybody's attention is that it reflected some of the things we do know. We have been trying to pull biology into psychosocial and into psychology, and so people were open to this idea, this notion that there'd be these kind of structured predictions from childhood experiences to adulthood. In some ways, we knew a lot about that. But I think what made it fascinating for the general public was, here's this checklist and a way to kind of guide all of us in understanding what that looks like. When Sharon and I first started talking about this, I think it might have been 2018 or 2017, she and I were serving on the Children, Youth, and Families Committee for the American Psychological Association. And we both kind of, in fact, I think, Sharon, we were in a group meeting and talking about ACEs, and both of us raising the question of, boy, it feels like we haven't done the work. It feels like we're very quickly using the ACEs questionnaire to address a lot of major psychological and social problems. And are we certain that the research is solid on this? And the answer was, we're not sure. And so we started exploring that and started reaching out to some of our colleagues who are experts in the country to take a look at this. So, really the ACEs, the timing of it, and Felitti, and I shared this with Sharon, Felitti actually spoke on our campus, as you recall, Paul, a couple of years ago. And in some ways, he was doing good work. He was assessing the needs of he was doing good work, assessing needs of his patients. And they kind of found this piece, and people started adopting it. But behind that piece is literally 150 years of developmental psychology that also needed to be considered, and medical and biological considerations. So, we've touched on that a bit in this special issue for the American Psychologist, but there's a lot of science behind that. We wanted to make sure that we paid attention to that. We wanted to make sure that the models are valid, because it felt like ACEs started to expand, and it might have led us away from some of those initial scientific findings.
One thing that jumped out to me in your writing was the challenge of even defining what an ACE is. Can you talk about that sort of foundational challenge of assessing this science?
Yeah, that was part of that conversation that Sharon and I were having, is that the initial pieces, I mean, the abuse, divorce, neglect, we have a sense of that, but people started expanding from the original study and sort of adding these different pieces, and it made sense. And so you saw people going beyond the 10 indicators that they usually that the Felitti and colleagues used into other areas, and some of those didn't necessarily have the scientific base and were an expansion of the ACEs construct, and so we thought, well, what's the science behind that? And that led to our further exploration of the construct.
Yeah. And Paul, you've really touched on what's one of the central challenges in the field and one of the current debates around the field. So when you talk about what is an adverse childhood experience, in that original study, Felitti had a list of 10 specific items that they had put together, really, again, from the observations they had made with their patients. That wasn't, really the line of inquiry that they had, so they didn't do the rigor behind selecting items that we would see in a lot of other types of studies. But those 10 things Mike mentioned, abuse and neglect and divorce, those sound very different, but the 10 items kind of lined up along two dimensions. One was things that happened directly to the child, like abuse or neglect, and the others were things that happened in the household, and kind of went to household challenge. So having a parent with mental illness, having a parent who had been in prison, and then divorce on there as well. So one of the challenges we always face in science that is haunting us a bit with ACEs is this idea that for scientific rigor, we like to do things in a way where they're very clearly defined. So when research begins, we want to see some consistency across studies. So Felitti defined those 10 items, and to ensure that the science is sound and follows scientific principles and people are consistent, there's a lot of work using those 10 items. And even today, as we're seeing a lot of even hospitals beginning to screen for ACEs, recognizing the value of having this added information to serve people, they're using those original 10 items. And I shouldn't speak for him, but sometimes I think Felitti and his colleagues would go, whoa, we didn't necessarily intend that those would be the 10 items for all time. But that's sort of the nature of the beast with science. So pushing back against that is, as Mike said, these folks who are saying, we really need to expand on that and think more carefully about what it is that we're talking about. And in a lot of fields like developmental psychology that's been around, for such a long period of time, where people have brought that scientific rigor to it, they've been able to have those debates. With ACEs, the train's left the station. You have people who are already using a lot of this good work to translate it into action, to make really positive change in people's lives. And at the same time, you've got scientists standing on the depot station waving at the train going, but wait a minute, we need to define that clearly to ensure that the science is really good. So that was, one of the major catalysts for those original conversations we were having about the need to do this work with ACEs, is how do we marry that and ensure that we're not losing the momentum, we're not losing the enthusiasm, we're not losing the good work that's already being done in communities, but we're ensuring that we have the good science behind it.
That's a great metaphor, the train leaving the station. And of course, the ones trying to slow the train down are the researchers, right, Sharon? Let's test that one more time.
It's a monumental challenge, because I think personally, when I heard about ACEs, when I started learning about them, there was sort of an excitement to the idea that there's a scoreboard. So you can take this test and you get a score, and that score reflects a result. It reflects some sort of an expectation going forward. I think that's natural to understand, but how in the world do you put an adverse childhood experience on a scoreboard? If you check one of those boxes off and you get a 1 point,
right,
that 1 point really could count for 100 points, depending on what that experience.
Yeah, and all experiences simply aren't created equally. All of us are very different in terms of how we might react to things. So one of the things I think is a good example and kind of highlights the controversy is thinking about divorce as an adverse childhood experience. We have, oh gosh, last time I looked, the divorce rate was still around 50%. So are we saying, that 50% of people have this challenge that the data say they won't overcome? They'll have cancer, they'll have diabetes, they'll be depressed. Well, we just know from our own experiences that isn't the case. Now, on the other hand, for some people, divorce is a really traumatic experience. Uh, at the other end of the spectrum, if you have two parents who are trying to live together and it's just not happening and everybody's really unhappy, not getting a divorce may be the traumatic experience in that family. So, how do you account for all these different considerations? And we don't want to default to just saying, anything bad that happens to kids is an ACE.
Mm-hmm.
But by the same token, we don't want to miss out on the opportunity to be responsive to things that are really salient right now. So, in our special issue, we had some people who had been working on various things. I know one really fine paper that was submitted was looking at immigrant children, talking about what we know is happening at the border with family separations. That would seem clearly to be an ACE. So how do we account for that, but at the same time not try and chase every new issue? COVID would be the other obvious one. Certainly if a child's in a household where COVID really hits there, that's potentially an ACE. But are we now going to call COVID an ACE? Now that's everybody. And if we cast too big a net, we've lost the meaning and the utility and the value of the work with the ACEs.
There was even challenges in, again, I became fascinated with this as soon as I heard about it. And one thing that it was kind of a push and pull for me was the idea that most of the people that I would consider my mentors, the people that I look up to, many of them have had adverse experiences throughout their life, and they've practiced some form of resiliency that has forced them to overcome those experiences. And many times that's why you look to them as mentors and people who could teach you the ways through the hard times. But the resilience factor is something that, again, is so hard to define. And of course, you would never paint an adverse experience as a benefit to somebody in later life because of the consequences of it. But for some people, it seems to be the case. And that seems to add in another challenge to this sort of defining science.
But also the promise of it, because that does, in my conversations with people who have worked in this forever, as well as people like you who are kind of new to the concept, this idea of resilience comes up immediately. And it's positive. I mean, I think all of us are drawn to the idea of being hopeful. So I think that notion of resilience is really going to be the future, and how do we marry that with the construct of ACEs?
Now, when we're looking at ACEs and the way that they're used right now, what are some groups, whether it's education systems, public school systems, or criminal justice systems, or who are taking this sort of science, whether perfectly defined or still evolving, and putting it to use or beginning to translate it into some sort of an action? And what are the results of that been?
Well, I think for us, one of the reasons that we ended up exploring further, the sort of examination of ACEs is that people were starting to use it in policymaking, and not always in an informed way, and that had us worried, because the intention of the original paper, Felitti and colleagues, was true. I mean, they were focused on their research question. The science was good on it. But it expanded so dramatically, and then people wanted to adopt it, because if you're a school system or a public health system, you want a checklist. You want something that can kind of help you assess risk and help you as you develop policy. But in the eagerness to move in that direction, expanded it pretty quickly, and I think that was the challenge. This notion of risk factors and protective factors, and there are other terms for it, promotive factors. They've been around for generations, for probably 50 to 100 years. I mean, depending upon how you define it. So we've always known that there are good things and bad things that people might have developmentally, or throughout their lives, that have an impact. I would say, and Sharon can give me her thoughts on this, but really that's the protective factors that have been sort of the newer group, because risk factors were easier to define, but boy, how do we counter that? How do we help with resilience? Because the thinking is, of course, as any kind of biopsychosocial framework, is that there's a measure of biology that people are born with, certain temperament and capacity to handle crises and risk. But how would you know that? And so then there are the other pieces, the environmental pieces, where we think we can have an impact. And so for a while, and I point to Emmy Werner, who was one of my mentors at UC Davis, and who she passed a few years ago. But she and Ruth Smith, they had a study which is remarkable. In 1955, they started a longitudinal study of all babies born on the island of Kauai, right? It was a perfect longitudinal approach because it's an isolated space back then, and there wasn't any tourists in Kauai, and it was a difficult environment. And so they followed these children until they were 19, 20 years old, and they looked back on, and many of them did quite well, and then some didn't do as well. Most of them lived in similar environments, and what was that? And some of it was a bit of biology, but that's where protective factors started coming into the literature, and really basic things. Werner and Smith, as I recall, always talked about how really what matters is you have one person who believes in you, one person who thinks that you can make it, and that one person is not your mother or your father, somebody outside of the family. And that was a remarkable finding. But also things like church and having extended family and participating in activities, those were important. And in this in the special issue, in fact, ironically, this is about Washington State. One of the studies, talks about that in the communities. So how are protective factors developed in communities, assuming, as Sharon, wrote in our article quite lovely, that it's not a matter of if, but it's like assuming that everybody has an ACE or everybody has some adverse childhood experience. And so what are the protective factors, and what are the features in your community that can contribute to that? So when we think about that, I mean, Werner and Smith, Emmy Werner never talked about ACEs. It wasn't developed during her time of research. But that construct of having a community around you to create safe environments and help you if you're born into a risky environment is still, things that we're addressing here with ACEs.
Mm.
And Mike knows he's singing my song, because my work has all been at looking at how do we approach things at this very systemic level. So I have always shown a lot of deference to those who work directly with individuals. I'm a great admirer of those. I tend to be a little too soft-hearted. I have to sit back and look at the whole big picture. For some reason, terrible statistics, I can keep going through that, but one troubled person just kind of brings me down. But I kind of think of the two ends of the spectrum, because really aren't each of us the combined experiences, good and bad, and then what we bring to the table, which sometimes is genetically in terms of what our disposition is. So kind of going to that idea of, some people can just take more than other people can. And so it's that combination, you hope that sensitive soul doesn't have as many bad experiences. Right. Not that you're wishing them on that person who has a little more resilience, but that person's going to be able to take more. Right. And still probably have a better outcome than that sensitive soul who has fewer adversities. Yeah. So it's a matter of kind of, in my mind, thinking, what are things we can do that really serve as good protective factors for everybody? Mm-hmm. So to echo something Mike said, it really is amazing when you look at this research that speaks to the profound impact of just one person in a child's life who says, you're going to be good, you can do this. So we've seen that come into play with mentoring programs, for example, which are great for kids who are facing a lot of challenges, but even for students who are doing well by all the markers we use, we see them benefiting from having that mentor in their lives. So what are those kind of positive things we can do on a really big scale? And then what are the things that are so bad we know we just need to get rid of them? So I probably shouldn't use this example because I need to go back and find this source. But years ago, I was at a talk and I remember somebody sharing some of the work that the US military had done when they were looking at post-traumatic stress disorder. And they were looking at people who had served in Vietnam. And what they found was that if somebody did one tour in Vietnam, uh, and then they would look at that group of people, there would be a certain percentage who would have PTSD. And then if they looked at the group who had done two tours, well, there was a considerably larger number now who had PTSD. And they kept going until they found a certain number where almost everybody had PTSD if they had done that number of tours in Vietnam and been exposed to that. I remember the speaker saying it was only less than 2% who didn't have PTSD, and they tested out as sociopaths. So, clearly there is a point at which nobody can take it. It's no longer a matter of personally what you can manage. It's just too much. And those are the things where from that systematic perspective we can say this is bad for everybody. So can we get rid of what's bad for everybody? Can we do more of what's good for everybody? And then there's a lot more work to do, but if we're looking at really the biggest impact we can have, that's where I at least believe the focus would be most beneficial.
I think that that's one of the greatest powers of this discussion is if I were to look out my window right now, there's not an individual in really the world that wouldn't relate to this sort of thing. You know that your foundational experiences provide your foundation, and that's the person that you build upon and whatever you become. So it's fascinating to everybody. And when you talk about systematic change, that's fascinating in that sense because that means that it's just about every system that exists that could incorporate this sort of knowledge into it. So as you
and there's great potential there. You reminded me of a phrase I often hear when we're at meetings with folks talking about ACEs, and they'll highlight the need to move the conversation away from what we've more traditionally done, which is to say, what's wrong with you? And to instead say, what happened to you?
Yeah, there's so many ways to look at those 10. I took the test in preparation for this just out of curiosity to see what the questions were. And looking at the questions, I think there was undeniable truth in the fact that if I answered yes to a few of them, I would assume that I would be dealing with the consequences of whatever that yes was later in life. Another question that came up in learning more about these is when you include the role of intervention, the intervention has to come, of course, later when those things have already happened to somebody and you can offer those coping mechanisms. But I think this comes back to your idea of systematic change. There's intervention that may be considered early on to prevent those experiences. So how do you marry those different pieces where there's different work in so many different areas all into this kind of one combined thing that says this affects everyone?
Mike, you figured that out, haven't you?
Yes, I have.
Just this morning, after your second cup of
Conversations with you, yeah. Yeah, to take a bit of a swipe at it, in this special issue, Paul, we have some just tremendous articles, really fascinating work. But as editors, Michael, Sharon, and I wanted to make sure that we represented the lifespan and represented different populations, and so we did that. And so we have studies in there that look at, perinatal, period for trauma. So if you're, if you're an expectant mother and you have a baby, and so what happens during and that trauma as that is experienced by that child perinatally, intergenerational issues, certainly, trauma that's been experienced by previous generation, how does that pass forward is an area of research, children in elementary school, young adults and such. And so, I mean, it's important that we look at all these different portions of life and these different experiences. So it's not just at one period of your life, and it may not even be directly you. It may be the environment of your parents that has an impact. And what does that look like? So in some ways, it challenges ACE's construct to broaden and to look at sort of a trauma lens, which is also a big part of the literature. And as you'll see in some of these articles, what the authors and the scientists are trying to do is integrate those constructs, which makes sense. How do we take trauma, ACEs, and resiliency and talk about how do we, identify needs, and then how do we treat them, assess them, and support them. So the other piece is, there used to be in developmental psychology a lot of work around critical periods. So if something happened to you at 2, it was more dramatic than if it happens to you at 12. We've gone away from that, but some of those concepts are still there. If you're 2 years old, you're more vulnerable to the environment, and you need more protection theoretically than when you're older. And at the same time, if you're 2, you may not really be conscious of the fact that your parents are in conflict all the time, whereas you might see that when you're older. So that probably doesn't answer your question, but that's sort of the context of this. And that's one of the reasons that we wanted to do this special issue, is we wanted to take the ACEs framework and say, this is great, but let's make sure it connects with all these other pieces and all this other work relative to trauma and resilience and developmental psychology.
So many of the questions.
It does take us back to that concept that all ACEs are not created equal.
Right.
And in fact, when we organized our paper, and the organization of the special issue looks at 3 important areas. The first one we've already talked about, which was how are we going to even define ACEs? And what is the importance of that? And the second one is this question we're talking about now, in terms of how are we really going to measure ACEs. We've just been looking at these events, but there's some really innovative work being done, some of which is included in the special issue, around disentangling the frequency of ACEs. So not just the number of ACEs you've experienced, but if you were abused once versus you were abused once a week. Are we seeing differences there? Looking at the type of ACE, the frequency, the duration, as Mike just alluded to, the time in your life that was happening. People are looking at maybe there are some unique combinations of ACEs that occur.
Mm-hmm.
We still keep coming back to this idea of how individuals experience things differently.
Mm-hmm.
So how to even, for lack of a better term, personality factors start to weigh into this.
Yeah.
What is it that attracted each of you? Dr. Lawler, we've discussed this in the past, but to this sort of study, to the study of experiences and how they impact people's lives from childhood on, what was the life experience for you that said, this is what's I'm going to work on?
Yeah, I'll say it because I've mentioned it to Paul, and Sharon can share hers. I mean, there's many things, but one of the things that was very enlightening for me is when I was in college and coming out of college, and I'd had a lot of experiences working with others and knew that I wanted to be in a helping profession. But when I worked with vulnerable youth and young people who were struggling, I realized that the difference between me and those struggling young people was minimal. I mean, it wasn't a whole lot of difference. So maybe they had an extra, source of pressure or trauma in their life that I didn't have, and that was enough to send their trajectory of development in a whole nother area. So even though I didn't necessarily see myself as a researcher, as a young clinician, but over time you realize that these broad questions are really important. They're important for policy and practice, and so that drew me to that. Like what really is the difference between all these people? Some of it is biological, and they have, people have fortitude and the capacity to move through these things, but it's usually not just one thing. And these other environmental qualities that help support or enable somebody to move through. Back to Werner and Smith, I just love their work, but they comment that about a third of that population from that island of Kauai in 1955, they turned out fine. But really the big finding that people don't always talk about is they say basically once somebody gets to past 40 or 50, they generally don't generate new problems for themselves. So it's actually a third of the young adults did well, and then nearly 100% ended up being fine. And I forget what they called it, but maybe it was a middle-age melancholy. I'm not sure, but that's not the term. So when I think about my own engagement in it, I always thought to myself that I was so fortunate to be able to learn, so fortunate to be able to do that work, and realizing that the differences between myself and these other young people were relatively small.
Yeah, and I'll out myself a little bit, but I won't put you on the spot, Paul. You said you took the ACEs quiz to kind of see what your ACEs score would be. The way that is typically scored is to say having 4 or more ACEs is really problematic. I have more than 4.
Mm-hmm.
And I've had a great life.
Mm-hmm.
So I, hear what you're saying, Mike, that you look at this, and I was actually at a community event not terribly long ago where they had everybody taking the ACEs exam, and this is a big community initiative. So this kind of shows you the level that ACEs is getting to, where they were having everybody take the ACEs score and kind of sharing some generally helpful information there.
Yeah.
But I was struck by the fact that people were saying, "Oh, I have 1, I have 2," and I think I was the only person who said, "Oh gosh, I've got more than 4," in a room of 200 people, and I thought, "Oh, come on now, people." So, I,
Yeah.
I would like to believe that's true, but part of me worries that people are still stuck up against this of, I'm not going to admit that bad things have happened to me. I'm not going to admit that I have challenges, and that historically has been our American culture. And I'm going to go back to that saying of, it's not what's wrong with you, it's what's happened to you.
Mm-hmm.
And if you've had a lot of ACEs and you're doing well, that's fabulous. God bless you.
Mm-hmm.
I'd like to talk to you, and let's figure out what we can share with other people who are not able to navigate the struggle as well. Let's be honest with each other. Let's help each other. Let's have the benefit of this knowledge so we can all do better.
Mm-hmm.
It must have been fascinating for each of you to have this opportunity to serve as editors for this work, for the American Psychologist, because of your experience and your passion for this topic. When you were going through some of those articles that are going to be included in this publication, what were some things that really stood out to you, and things that you're excited for the general public to be able to see and to get a better understanding of?
Oh my gosh. The main thing that strikes me is how many people were responsive.
Mm-hmm.
So the way the publication process works, as you may know, is we put out what's called a call for papers, saying, here's the kind of work that we'd like to produce. If you're doing work around this, send us the idea for the articles that you have. And we got almost 200 people who had really great ideas. And this is going to be for a journal that typically includes about 15 articles.
Mm-hmm.
So then the game is, how do we take these great ideas and go down to the most promising ones? And we, invited a lesser number of people, thinking they won't all come through with the article. They won't all be of a great quality. But we had so many more really good articles than we could include in the special issue. And in fact, I just heard from one of our authors who we couldn't include 2, 3 days ago, Mike,
Yeah.
that their article has already been published in another journal. I mean, it was just the quality of the work and the breadth of the work was what was really amazing.
Yeah, I agree. And there's a lot of different subject areas that I think people will be surprised that are in here. Looking at different populations, veterans, African American communities, Mexican American communities, studies from other countries, looking at various developmental periods of life. Just a lot of very interesting places where ACEs has expanded. And again, ACEs were trying to dig further at the science, but already people have taken that construct and applied it to all these different areas. So it's a wonderful way of bringing all those pieces together. The other neat thing is that we're able to bring in different areas of study. So we talked about resilience. There's a really terrific article here relative to neuroscience, which is a major area of study now in psychology. So bringing all these different pieces together, and we wanted to make sure that we got as much representation regarding population and concerns and subject areas. And I think I feel pretty good about that representation. Would you agree, Sharon?
Yeah. And it occurs to me as you're talking, Mike, it may be helpful to again revisit how we organized the special issue and how we organized our article around those 3 questions. So we've talked about that big definitional issue. Then how are we going to actually measure ACEs? What are the characteristics of ACEs that are important? And then the third and largest section was looking at the translation of the science to action. And that's where we began looking at things that were happening in schools, things that were happening in hospitals around using ACEs for screening. And that's where you really begin to see that this could be helpful in so many different domains. And it really takes us back to the importance of, if we're going to do things well in so many different areas, how can we use what we're learning to make that science better so that the action is better?
So the conversation around ACEs, of course, it's been around for a long time. Like you said earlier, Dr. Lawler, I think everybody has known for a long time, if something bad happens to you as a kid, it might have direct ramifications through life. But the term ACEs itself has really only been around for a little over 20 years now. In those 20 years, how have you seen the evolution of that? And I think that one major way that you've kind of highlighted is the incorporation of all these other sciences that have been defined and been around for such a long time, and they have direct translations into this sort of research and translation into practice as well.
Yeah, I think that's part of the magic, and that's part of what we wanted to accomplish. We were a little worried that ACEs was going to be something that people were doing, but not necessarily, and the science would get away from us on that. So we wanted to make sure that we connected the science back to ACEs, and in doing so, we've connected, I believe, different areas of science, different areas of psychology to the ACEs framework.
When you look at it going forward with this release, what are your hopes for putting something out like this that's kind of a comprehensive look at this issue? And the 200 plus articles that came in, I think, is directly reflective of the difficulty in defining itself. And releasing all 200 of those, of course, not through one issue, but in many different forms, may be beneficial, because somebody could look at it and say, that was an adverse experience that I had, and I didn't realize that there was somebody who relates to that adversity, and that there's really something that I could channel here and discuss. So going forward and putting out this special issue, and what are you hoping for the impact of that on policy, on all the different things that may factor in here?
Well, Sharon needs to comment on that. I mean, Sharon is our first author, and deservedly so. You know, she and I started this conversation, but she really made sure that we did all the early work to get to where we're at today. So I really want to give Sharon a lot of credit, and well deserved. So when I think about what we've done, and Sharon can talk about sort of the formal questions that we posed and what we achieved, and we asked our other author, Dr. Roberts, his comment, and he said he's excited, but that's not the right term. He wasn't quite sure which term, but he's excited by the research because there was so much interest in good science. I mean, it's not like we had to reject bad articles. These were really fine articles, good science, good work, but there's only so much space. So we know that we help generate, kind of a reflection on ACEs after 20 years. How do we integrate that? How do we apply that to different populations? I feel best about that. And going forward, I think the special issue represents a pause in the ACEs development where we say, okay, field, where are we going? And how do we make this work? And how do we apply this construct? And how do we marry it with other areas of science? So, and I just, for us, it's a beginning the conversation. It's sort of compelling the field, not just psychology, but health and medicine and other allied sciences, to take a fresh look at ACEs and to up our game relative to science. Sharon?
Oh, it's such a challenge, but I think the potential is enormous to do just what Mike was talking about in terms of how can we really bring together all of these very different areas of expertise around similarities. How can we talk a similar language? How can we work together to be more than the sum of our parts? The typical model, I mentioned I've always done this systems work and taking research to action, putting science to work. But I've always been struck that the model is really this idea of we'll do really good science and then we can hand it to those people who are going to use it. And that just isn't going to work. My other metaphor is that instead of doing a handoff, we need to grasp each other's hand and keep going down the road together. We don't need the scientists standing on the platform and the people working in the community on that train speeding off. We really need to continue that conversation. It isn't a matter of we do the science and then you apply the science. People who are doing the application are learning stuff that can make the science better. So if we can just get everybody to work together and have that more collaborative vision, the potential's endless. And I think ACEs has such promise because it has caught the public's attention and it resonates with people. So there's kind of a vested interest in both groups in engaging the public. So maybe that can help drive us to solve some things that we've stewed around about forever, and see some really major progress.
So for people who are interested in this, how can you access this release? And we'll be timing this release of the podcast alongside the release of the article and the publication itself. How can people who are interested access that?
Well, it'll be online. The American Psychologist is online. Many articles will not be available unless you have access through a library system. But you can see, I believe you'll be able to see the abstracts of all the articles online, right, Sharon? I'm a little bit clear about that.
I believe so.
Okay.
I know anybody, and y'all probably have a lot of people in your audience who are university affiliated. You can always go through your university library system. They'll have a way to get you online access to that material. If you're somebody in the community who doesn't necessarily have access to a university library, I'm not quite sure how to do that. But I can tell you a good place to start and just getting some good information. And if you've paid your taxes, you've paid for this. So you go to this site, is the Centers for Disease Control and Prevention. Just go to your computer and type in CDC ACEs, and you will pull up a lot of really good information, much of it targeted to different specific audiences, like parents, for example. But for schools, I know they've got some good separate information there. So you'll get more information than you want.
That sounds great. Well, I want to thank you both so much for joining me for this conversation. It's so important, and in such an evolving discussion, I'm sure that we'll connect in the future to have further discussions on this, because it's still, especially in terms of science, a very young little seedling here that's growing in all these different directions. And there's so much great potential on so many different people's lives. So I'm really excited to continue exploring and learning more, and to continue having these conversations.
Great. Well, thank you so much for talking with us.
Yeah.
Of
Thank you,
course.
Paul. And thank you, Sharon.